Hello everyone, today I'm presenting my analysis on lung cancer patient outcomes. I'm Jin Li, and I will show you what our data analysis reveals about risk factors and global patterns. Lung cancer is the leading cause of cancer deaths globally, so we need to identify high-risk groups early. Our research question is, how can we identify key characteristics of high-risk individuals and build their risk profiles? We have three specific objectives. Which variables predict mortality? What affects 5-year survival? And which characteristics predict final outcomes? This is take us from individual factors to complete risk profiles. In this dataset, we analyzed over 460,000 patients from multiple countries. Average age is 60. 5-year survival rate is 50%. Our approach is individual factors, then geographic patterns, then intervention strategies. Let's identify the key characteristics for risk profiles. Look at the smoking status. Former smoker, non-smoker, and smoker all shows the similar patterns. About 6 to 7% get yes predictions. This tells us smoking matters, but it's not everything. Screening availability shows almost identical results. Mortality risks around 50% with or without screening. Screening helps, but other factors are more important. And look at the family history. Family history combined with the smoking shows the risks between the 49.8 and 50% around all groups. Small difference, but they accumulate. Individual factors alone aren't enough. We need big picture. To identify high-risk individuals, we need to understand the geographic and economic factors. Look at the world map. We can see Japan shows the highest risk at 3.42%. South Korea and South Africa also shows the high risks. And we can see East Asian countries dominate the high-risk zones. Geographic location is crucial for risk profiles. Now the heat map reveals something important. Blue means good outcomes. Red means bad outcomes. Look at the middle row. Middle-income countries shows interesting patterns. Middle income with good healthcare access shows blue, indicated a better survival rate. However, when we look at the high-income areas, many shows red colors, especially when combined with limited healthcare access. This suggests that healthcare accessibility can be more important than poor income level for patient outcomes. Let's look at these bubble charts. The bubble size represents the number of patients, and the color shows cancer stages. Interestingly, the three smoking groups shows very similar stage distributions. Former smokers, no-smokers, and smokers all have the stage 1 between 6.6 to 6.7%, stage 2 around 10%. Stage 3 between the 6.6 to 6.7%, and the stage 4 close to 10%. This finding is quite important. Smoking status doesn't significantly affect cancer stages distributions at diagnosis. This suggests that other factors may be more important in disease progression. The cycle on the right shows diagnosis delays, and here we have a very important systematic pattern. Cycle size represents the patient numbers, and the color from green to red indicate delay levels from low to high. Let's look at list combinations carefully. The largest dark green circles represent the over 150,000 patients. This is the middle income plus the good healthcare accessibility combination, shows the shortest delay time. In contrast, high income but limited healthcare accessibility, as well as high income plus poor healthcare accessibility, both show the dark red, indicated are long delay times. Low income but good healthcare accessibility also shows large light green circles, with the moderate delay levels. What does the pattern tell us? Healthcare accessibility is the key factor affecting diagnostic delays, not just economic status. Middle-income countries with good healthcare systems actually perform better than high-income areas with the poor healthcare services. Let's look at the age. The age versus mortality risks chart below shows something interesting. Look at this line. It's almost flat. All age groups has mortality risks around 50%. Age doesn't have much impact. What matters is the combinations. So, risk profits need to multiply factors work together. Age versus mortality shows a flat line around 50% across all age groups. Age doesn't matter much. It's the factor combinations that count. Let's move into key findings. These have three major discoveries. First, geographic clustering matters. Japan leads at 3.42%. East Asia shows the highest risks. Second, healthcare accessibility beats income. Middle income plus good healthcare shows better outcomes than high income plus the poor healthcare. Third, multiple factors work together. Risk profits need to complete picture, not just single factors. So, based on these findings, here's what we recommend. In international level, prioritize healthcare infrastructure in high-risk regions like East Asia and South Africa. Healthcare systems level, we should focus on improving accessibility rather than just income. Reduce diagnostic delays through better integration. In individual level, we should use multi-factors risk profits, combining smoking, family history, location, and healthcare access. In conclusion, we analyzed over 460,000 patients and found that geographic location matters, healthcare accessibility beats income, and multiple factors work together. There's evidence-based profits can transform how we identify high-risk individuals. Thank you.